Respected physicians, this is our 108th session of ECG study group's monthly presentation session. And today we have Professor Dr. Azizul, sir, Eminent Physician, Division of Cardiology, Emory University School of Medicine. As you all know, Azizul sir is giving lectures on ECGs for the last 2 to 3 years in our platform. And he is a very important member of this group. Sir has always kind to his lecture and provide us the simplest way of understanding ECG along with the clinical presentations. So I'd like to request Professor Abdul sir to start his lecture session. Ajit sir.
Thank you very much for your kind introduction. I'd like to discuss some cases with ECG. It's important that sometimes we need to repeat very common things because this lecture is specially designed for trainees. That's our primary goal. And ECG itself, we need to understand, we need to interpret it very systematically so we don't miss anything. And so that if we can go systematically, then we can just look into what the findings are, and also always you need to correlate with clinical information, because ECG itself is not simply a diagnostic tool, but it's not a final diagnosis. So we'll discuss a few things in that regard. And I do not have any disclosure, no interest in financial, also no financial interest in pharmaceutical companies. With that in mind, I'll go ahead and start this ECG. This first case we have, 73-year-old female just presented to the emergency room with passing out spell syncope episode. Okay, patient has type 2 diabetes. Important information that we have here: his initial high sensitivity troponin was 67 and went up to 450 in 2 hours. But definitely he passed out, so doesn't recall what happened that time. But this is the ECG that we have. Have a quick look for 30 seconds, then I'll give you some questions to poll. And we'll definitely thoroughly discuss the ECG. So let's have a poll on that ECG. So first of all, is it a second degree AV block, type Mobis type 1? Is anterior subendocardial ischemia, inferior MI, blocked premature atrial complexes? Once again, I'm putting the ECG there. And I'm putting it for poll again.
Amrul bhai, keep the poll for 20 seconds.
20 seconds this year. এই পোলটাকে আবার দিব?
না না না, এটা আপনি পোলটার রেজাল্টটা পাবলিশ করুন।
Just result then.
পোলের রেজাল্টটা দেন।
All right, A and C, okay? All right, let's discuss the ECG. Okay, here what we have, definitely we have few things. First of all, we had major concern we had here. Let's look at the P wave, PR interval. Then one P wave is blocked or something happened there, okay? So no conduction through that. And then the second conduction going on. But if you look at that carefully, carefully the peer interval here and peer interval here, and then definitely the shorter peer interval here. Okay, and immediately before that, the peer interval was a little bit longer, though we don't have much further information there, but it's possible that there could be vein cave going on, Mobius type 1 in that area. But also, we need to make sure that we look at other things on this patient also. As we understood, the patient came here for syncopal episode, and we saw that we have evidence that her troponin went up from 67 to 450. Look at what other the findings we have. We see some ST depression here, maybe slight, but mostly here, but more prominent, a little bit here. And there's some ST elevation here if you look at the baseline. If you look at the baseline here, if you look at the baseline here, if you look at the baseline here. So the patient, yeah, indeed have, if you look at that, looks like that patient had, inferior posterior MI, and it is probably acute ST elevation MI. And patient had heart catheterization done and was found to have 99% diffuse RC obstruction. And also it's not very uncommon in this type of patient to have 2:1 block, type 1, Mobius type 1 block in this type of patients because of AV nodal, blood supply they have due to that. So in that case, the main learning point that we have, not only the AV node, but also its connection to the, our inferior posterior MI that the patient has because of the blood supply to the AV node. So I think the people who answered A and C, they're more correct, but it's inferior posterior MI. But definitely the main findings we have both conduction abnormality and also at the same time the patient had inferior posterior MI. Because this is a common scenario. Sometimes we see these type of patients in the emergency room. So we need to carefully look at these type of things, that ST depression in sometimes they have V1, V2, V3, but some people had very subtle ST depression that you don't want to miss, and very minute, very very small ST elevation that inferior posterior MI, that's sometimes it's not very obvious. So clinical suspicion should be very important in this type of cases. Let's look at the second case.
Azizul bhai, acha,
Yes.
just one. Regarding the first case,
Yes.
acha, the previous one,
Mhm.
can you show the ECG again, please?
Yeah, that's the ECG we have here.
Yeah, this one. Acha, will you suggest there is the temporary pacing during the coronary intervention during of this patient?
Absolutely not, because the reason is inferior posterior MI. No, during the intervention. Okay, during the intervention, sometimes they do a temporary pacemaker because if you engage the right coronary arteries, it's pretty significant osteal lesion. Sometimes it can slow down the heart rate, but it depends, how the patient behaves that way in the cath lab. But since it is not, you can argue with that whether prophylactically you will use that. Okay, but a lot of interventional cardiologists, they do it because there is a suggestion when you engage the right coronary artery, they can have progressive block. But they will definitely not need permanent pacemaker. They will definitely not need permanent pacemaker. Temporary pacemaker is a possibility. You could use that as a special precaution.
So one more question, Azizul bhai.
Mm-hmm.
If there is no scope for the immediate coronary intervention of this patient, will you suggest thrombolytics for the patient? Thrombolytics?
Yeah, it is inferior posterior. It is basically a STEMI. Okay, it is a STEMI because you can see. Sometimes it's difficult to understand when there's subtle changes there because here ST elevation is very minimal. You can see that. Only lead 3 and AVF you can see some, but if the patient is better, is a patient has troponin elevation like 67 to 450 and this type of changes there, ideally, yes, he would be a candidate for that. But question right now, sometimes very difficult to determine with these subtle changes of the EKG. In those situations, you can do a quick echo and you see if any wall motion abnormality in those areas, then probably would be appropriate to do that. Okay, but
Sir, can I interrupt for a second?
yes,
If the ST elevation doesn't, is the apparent ST elevation which doesn't meet the criteria of thrombolytics, is it advisable or is it prudent to give thrombolytic? We can go for cath, cardiac cath, but giving thrombolytic without the appropriate ST elevation, can we give thrombolytic? As per
in this particular patient, it would be difficult. I agree with you. Because reason is, I would probably prefer him to go for cath because here's a question about, because the changes that we have in this particular patient is very subtle change, very small ST elevation, and patient did not present with chest pain. Patient present with syncopal episode, but has troponin elevation. Subtle changes, and question right now, but ST depression in V2 lead, little bit there, little bit V4, there's some ST depression. And you can do a posterior ECG. If you confirm that ST elevation in posterior ECG, then you probably could do that thrombolytic therapy if you have no option. But I would probably do a posterior ECG on this patient first to confirm that. Because otherwise, best option for him, for the patient to go to the cath lab. He's 73 years old, and we don't know what's our other underlying, except for diabetes. I know it's a difficult question but cath would be more appropriate in this patient.
Yeah, thank you, excellent.
Mm-hmm.
Thank you, sir.
Yeah, and absolutely, you're right on that. Whether we need to take a risk of doing, thrombolytic therapy in this patient. But there's subtle change. Do a posterior ECG, and you can confirm that ST elevation there, and troponin is there. So then you have some leverage if you don't have any option of doing a cath within a certain period of time that are required. And also, second thing is that if echo available and bedside echo, you can see wall motion problem, then it could justify doing that. That would be my approach. Otherwise, cath would be better. Mm-hmm. Yes, sometimes you don't want to take unnecessary risk.
Yeah, one more
I have a question, sir.
Yeah.
Mm-hmm.
I have a question, sir.
Sure.
Can you explain the syncopal attack by seeing this ECG? Have any evidence?
Yeah, most likely there's a possibility with it. He had progressive block a certain period of time that made him probably passed out. Because here we have 2:1, but this type of patient can have progressive block, heart block, because of the avenodal artery problem, and heart attack itself can cause that.
There is a possibility of the intermittent complete heart block, Zaman.
Yeah, that's what I'm talking about.
Yeah.
Otherwise.
This patient has got the evidence of the secondary AV block, and at that time, when the patient actually passed out, at that time he had got the probably complete heart block.
There's a very good likelihood, and that's the first question Dr. Atahar sir already mentioned about that with the patient. We need to do temporary pacemaker during that, and it would be prudent to do that because we already have some information that patient had syncopal episode. Okay, so prudent to have temporary pacemaker when you intervene in that artery.
Azizul, actually,
yes,
we have got good panelists here. For my personal knowledge also, that is this is a very burning question in our daily practice and CCU. In this such a type of the doubtful cases when there is a elevation is borderline or doubtful, is there any harm if I give the lytics? That is the in such of the cases, what is the harm?
You need to look at this. What's the risk of giving thrombolytics? Okay, if you falls the criteria that is safe to give it, I'd probably give it. Okay, because if we posterior ECG confirm the ST elevation there, and we have some suggestion of that, and patient clinical scenario tells us that patient most likely had infraposterior MI, having some passing out episode, have some a block going on, AV block, most likely had advanced block during the time of, syncopal episode. So the clinical scenario might suggest a patient, precipitating event, probably the heart attack, MI, that caused the secondary problem. So we could do that thrombolytic therapy with all this constellation of the symptoms, provided that we don't have any option of doing heart catheterization.
So, Aizbhai, Assalamu alaikum. I
Also,
politely disagree. This is not an EKG for lytics because the EKG has two parts, STEMI part, the MI part, and the ST elevation part. This EKG doesn't have any ST elevation. However, I would support that if there is a patient who is behaving like an MI, chest pain, 10 out of 10, diaphoretic, V-fever rest, and no cath lab, then the risk benefit far outweighs in favor of lytics, maybe. But in this case, patient has one episode of syncope. Patient is doing fine now. At this point, the 73-year-old lytics is not benign. And we know from the TIMI study group's earlier studies that the ruled in non-STEMI, there the lytics did not do well because we don't know whether this is a subtotal or partial occlusion, because the problem with the partial occlusion, PCI does perfectly fine, but those patients do not do well with lytics, and we know that from multiple studies. So in
No.
this case, I totally agree that we can do the cath, but I would not give lytics, definitely, because the patient is alert awake, and this is also not enough to explain, because we can assume many things that this is a high-grade AV block may have, but we don't have enough document. So I would agree with your first proposition that maybe we just be taking to the cath lab and
cath lab, yeah.
what do we do? But without knowing further, I think it will be not a recommendation by any society guidelines at this point.
Yes, Dr. Hassan, main concern we definitely, first option would be cath. There's no question on that. But if they don't have any cath option at all, and we see posterior MI, inferior posterior MI, whether there's any option, that's the question they're asking. Okay,
Yeah,
but
and
definitely,
then look at the troponin rise.
yes,
Because and then look at the echo. But I would probably give, in this case, DAPT and heparin, and then wait and see, and then
okay. I
we
understand, but
can
yeah,
argue.
first option would be cath. There's no question on that we discussed earlier. All right. Any other question? I know it's difficult sometimes in real scenario, and particularly if we don't have option on the cath.
And by the way, I just wanted to tell you another thing. These kind of patients, we need to look at the totality. For example, patient may had a arrhythmia and then troponin went up. Patient may have hemoglobin 6 and then came in with the syncope, and then we do the EKG, troponin high, and then we regret, oh, hemoglobin is 6. So this indicates that there is an ischemia process going on, and patient had syncope. That's the fact, and we need to work on that.
No, I understand. Provided that all the other factors are okay, you understand, because and that's the understanding of this particular patient. No, I agree with you. Definitely, our first option would be cath. That's always we prefer in this type of situation, as I mentioned. But but if they don't have option, I'm not sure whether to leave him
And
alone
I tell
like
you,
that.
we see quite a few patients with this, particularly elderly. They may have aortic stenosis. You take them to the cath lab, you'll be surprised something else is cooking. So what I'm
No, I
saying,
agree.
when we are in the spot to give an opinion, I think we need to look at the totality of the patient. Thorough exam background, because EKG alone cannot dictate. I think we need to look at the in totality.
I totally agree with that. Definitely, patient, any decision you make, all the full exam and echo should be done quickly on this patient. Blood work, complete blood work, BM and CMP, all information should be available before making the decision. I agree. Any other questions?
So can we proceed the second case?
Yes. Now, interesting, that's this discussion we need to have held. All right, this is
Yes, sir.
another young lady that basically a runner, okay, and participates in the university sports. And she has some degree of, only symptoms, she has some degree of dyspnea on severe exertion only, but otherwise no other complaints. And vital signs stable, echo looked normal. And this is the ECG on presentation. You can look into that. It's not difficult ECG, but still we'll discuss about management plan on this patient. And I like give 15 seconds more. That's the current ECG when it presented to the office. And she had another ECG in the system about 2 months ago that looked normal. I'm going back the current ECG. I'd like to, if anybody on the, our trainees comment on the ECGs. Please feel free, because this is not a difficult ECG, but look into that. This is the current ECG, and patient had normal looking ECG 2 months earlier. Anybody from the trainees would like to comment on that ECG?
Please, if those who are interested, please raise your hand on
Yeah, raise your hand, please.
chat box. Or okay, sir, I have a question.
Yes.
Is it totally sure that two ECG are the same patients?
Same patient.
Okay.
The patient is otherwise asymptomatic except for only some sort of short of breath on severe exertion.
The patient
When she runs in the university system.
Yes, Dhriti.
Okay.
Salam sir, I think the patient has hypertrophic obstructive cardiomyopathy along with WPW syndrome.
You're expecting both of them or one?
WPW can be an association of HOCM.
Mm-hmm.
WPW, I'm sure, but there can also be HOCM.
All right. So what you're going to do on this patient, just have a poll, because you have to, patient is in the office and you're discussing, there's some several questions comes along. We see some change on the ECG and we have to give some advice to the patient what to do with the patient. Given the ECG 2 months earlier was normal, so whether we can let her go to full sports activities, patient should go to, EP study, patient should undergo any exercise stress testing, or we should just restrict her from participation of university sports. Let's have a poll. There's practical questions will come into play when the patient is in your office and patient wants to run. All right, so we have some results. So most of them chose 43% is stress testing. Anybody from the trainees can explain why you chose that test? What is the explanation of that, your underlying thoughts? Just feel free to answer that question.
Dr. Dhriti, are you interested to answer this?
Yeah, please, we are just learning here. Okay.
জি স্যার 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 আমি ওই যে ইপিএস স্টাডি দিতে চাইছিলাম কিন্তু ওই পোল একটু আগে এসে গেছিল তো ওই জন্য আমার সি এসে গেছে এক্সারসাইজ স্ট্রেস টেস্টিং আমি ওনাকে ইপিএস স্টাডি দিতাম কারণ হলো গিয়ে ওনার যেহেতু ডব্লিউপিডব্লিউ প্যাটার্ন ডব্লিউপিডব্লিউ সিনড্রোম আছে ওই জন্য হলো কি ওটা কনফার্ম হওয়ার জন্য
সো আপনি আপনি দিতে যাচ্ছেন ইপি স্টাডি বি না নাকি না সি
বি
Okay. Acha, let's rationalize that. Let's discuss that thing, okay? And we need to understand exactly what's going on. If you look at that, we know that the patient has WPW. Okay, we saw that in the initial first ECG, though 2 months earlier, his ECG is normal. When you have WPW, as for example, the sinus beat, electrical impulse going on, that's the normal conduction that will look narrow, complex QRS. If part of that impulse goes through the accessory pathway, that causes the pre-excitation. That's definitely we all understand that, right? That's the pre-excitation. It's wide, bizarre-looking QRS initial phase. That's the part of the impulse. How many percentage of the impulse goes through this pre-excitation? That determines how much delta wave is going to be here, pre-excitation going to be here. It could be 10%, it could be 20%, it could be 30%. That will determine how much pre-excitation is going to be here. And that's the thing we need to understand, because EP study is definitely an invasive procedure, okay? Whether we need to go directly for that, there's some rationale behind it, but whether we need to go first, that treatment, that procedure or not. I think initially the patient has been really running for a while, right? And she's a runner in the university, and she normally doesn't feel any discomfort except for some short of breath at the very heavy exercise activities. But we need to determine how much excitation goes through that, and if the patient really runs certain level of period and heart rate increases at certain level, whether this pre-excitation impulse becomes dominant or it doesn't matter when the patient runs fast. Because we need to do one important thing, that is, with increase in heart rate, how much pre-excitation goes through that, because that will determine what to do with this patient. If with increasing his heart rate, the pre-excitation diminishes, then he might not need any further intervention. I'm talking about temporarily, okay? But let's, because as for example, like you let the patient walk on a treadmill and his heart rate increases, like you saw some pre-excitation, and then further you just increase the level of the exercise activity, level 2, level 3, it goes. And then you might see that this pre-excitation might disappear. It might become a little bit narrower. If you see a narrower QRS complex, that means when the patient gets heart rate higher, that pre-excitation area, AV accessory pathway, becomes a little bit refractory with higher heart rate. Then it gives you a clue that the patient is not in danger for having, bad problem. I'm talking about too much pre-excitation through the pre-accessory pathway. So some patients will be surprised that their pre-excitation diminishes with higher rate of heart rate. So if you can determine then he will be safer to do exercise. Okay? Definitely ultimate treatment is going to be ablation. That is true. That's the ultimate treatment for this patient, like accessory pathway ablation. But do you ablate the patient if with higher heart rate, QRS complex become narrower? It can. Those type of patients may not need ablation, because if, as for example, a heart rate is 60, you see that, and when the patient is exercising, heart rate is 120, 130, that becomes refractory, and then most of the impulse goes through the AV node, and the QRS complex becomes narrower. Those type of patients may not need ablation because they are safe to exercise, and they are not going to degenerate to, if the patient has AFib, they're not going to degenerate to, ventricular fibrillation or something, going through too much impulses through the AV, pre-excitation pathway. So that's kind of gatekeeping mechanism for us to test that whether this axillary pathway becomes refractory with higher heart rate. If becomes refractory with higher heart rate, then you may not ablate the patient. I definitely like to get input from Dr. Atahar Ali, if you can comment on that.
Thank you, Azizul, for your excellent case. There is a group of the patient who has got the intermittent pre-excitation, that is the accessory pathway. There are multiple factors that control the refractory period of the accessory pathway. And depending upon the correlation between the refractory period of the accessory pathway and the normal conduction system, that is aveneural system, the pre-excitation may be intermittently observed in such cases. And this patient, many of the patients may have the symptomatic tachycardia, some patients may not have the symptomatic tachycardia. I think your suggestion is very good, excellent, to find out those cases who need the really ablation, and some of the cases this can be followed up. Really, that's a good suggestion. But intermittent pre-excitation is a group of the patients. And if these patients are symptomatic, they are also candidate for the ablation. So intermittent pre-excitation may happen and can be observed in our clinical practice and depends upon the refractory period of the accessory pathway. Thank you.
Now, that's the important point, Dhriti, because you need to define, that's why exercise stress test is a good tool for you to make a quick determination what to do with this patient, would you allow her to exercise. Because you can, in your office, you can see with higher heart rate, excitation becomes less. Those two patients are less risk for having problem. But if the excitation gets worse with higher heart rate, then you should stop the patient exercising, send to the EP, and get ablation. Any other questions on this particular patient or discussion? All right. One thing that I like to look at the next ECG, just for your visual memory, keep in mind, these type of patients are really, with atrial fibrillation with axillary pathways. Because this is a visual memory that you can do. If you see this type of patients, you need to be more concerned about that. Because look at that, how this ECG look like. It looks like initially could be, you might think about ventricular tachycardia going on, but look at that, they're very irregular, very irregular. So it is definitely atrial fibrillation, and normally the heart rate is very high on this patient. And most important thing to look into that, look at the base of the complexes and width of the complexes and amplitude of the complexes. They will vary, because sometimes they are narrow. Look at that here, look at that here, look at that here base. Sometimes they are narrow, sometimes they're wide, sometimes the amplitude is different. That the reason it's happening because part of the impulse that goes through the AV node, if most of the impulse goes through the AV node, they'll be relatively narrower. If amplitude might vary with that. So if you see this type of ECG and irregular rhythm, it's AFib with RVR and with bypass tract. Okay, so and this type of patients definitely, if they're unstable, they're definitely unstable. If they are unstable, definitely you can do electrical cardioversion. And otherwise, option is, that's classic board question, IV procainamide or amiodarone, you could choose. But long-term solution, definitely catheter-based ablation, they're highly effective. So you need to send those patients to EP. But remember this type of ECG, it will come to your board question. All right, let's look at another case. This is a 34-year-old female with history of diabetes, presented to ED, mainly generalized weakness. Okay, And this is our ECG. Let's look into that. There are several things going on here. Look at how the ST going on in V1, V2 lead, bizarre looking, sometimes Brugada looking ST. Look at the T waves, how they look like. So I'm giving you a couple of seconds. And also maybe some slight ST depression there, but that's not very obvious. But definitely look at the T waves. They are high peaked, very narrow based. Okay. And patient waited a little bit longer, and we see that. So anybody from the trainees would like to comment on that?
Dr. Alauddin, please.
I'm going to show first ECG, and then it progressed like that, waiting in the ED, half an hour. Okay.
Dr.
And
Alauddin wants to say something, I guess.
It could be hyperkalemia, sir.
No, this is absolutely correct. Okay, and patient, look at few things. Patient had a potassium level of 9.5 at this stage. Okay, that's wide, and then we just the patient is going to be aggressively treated with sodium calcium carbonate, sodium bicarb, insulin with dextrose, and then it's slowly normalized, but still the same patients like progressed and then normalized. Okay. So you need to definitely first of all, a few things here. The question about whether there's ST elevation going on is a Brugada-like syndrome here, but definitely peaked T wave is a concern that we are first priority that we had. Okay, and since it progressed. And that level is still there's some peak T wave there. So high suspicion for hyperkalemia should be on board. And one important thing that the peak T wave, they are narrow based and very sharp peak T waves. One difference from ischemic T wave, early hyperacute ischemic T wave, is that this first part on ischemic, T wave is a little bit more. They have more slope here, because that part makes you ST elevation further if the acute occlusion going on in the artery, coronary artery. And this part, you see, this part in the ischemic T wave, hyperacute T wave, they're more like slurred and more slanted that way, and that part goes up and causes ST elevation over time in acute occlusion. But in hyperkalemia, they stay like narrow based and symmetric way. You can see that, and in acute hyperacute T wave, it is more slurred, and this part is more slanted to that way because that causes ST elevation in the future. That it goes up slightly and causes the ST elevation. So, and I'll give you some. Yeah, go ahead.
Sir, যদি কেউ এই ইসিজিতে এভিআর দেখে V1 থেকে V3 দেখে থ্রম্বোলাইসিস করে ফেলে বা থ্রম্বোলাইসিস ডিসিশন দেয়, what are the danger in it?
First of all, should not. Okay, the question right now we don't know. We don't have enough evidence of that to give thrombolytic therapy, and we need to at least have some blood work, and blood work shows like very high potassium level. Okay, always danger of having CNS bleeding. There's some certain percentage that is not acceptable. All right.
So sir, sometimes treatment itself may complicate the situation.
Absolutely. Now, you need to have some, as I mentioned about ECG is not always the diagnosis. ECG is a part tool. You need to have the whole patient together that we repeat again and again. You need to have complete physical exam, complete scenario of the patient, and blood work, at least CBC, basic metabolic panel, CMP, you should have it on board. And we can see hyperacute Q wave. You need to, peak T wave. Then you need to at least have some blood work done before making any decision. When you have potassium of 9.5, you know where you are. Okay, and within 20 minutes, actually, patient reversed to that level after correcting that. Okay. So you can have quick decision making, and if you do the appropriate treatment, you can reverse that situation very quickly. Because your first goal in severe hyperkalemia, you can take the potassium out from the body. You have to internalize the potassium, into the cell. That's our primary goal. Okay, that's why you give the calcium carbonate. You can get the sodium bicarb, insulin treatment that helps you to internalize the potassium. So you can have intravascular potassium. It will be less, but it goes inside. But you're not taking out. For taking out, you need to give Kyaxalate, those type of medication, resin binding substrate that can bind the potassium out from the body. In certain situations, definitely dialysis is an option. Another ECG I'll show you. Look at that hyperacute T waves. Okay, just give an example. Always be careful looking into that electrolyte abnormality. Definitely should not miss it. And after correcting that, it's normal. Hyperkalemia 6.5 to about 8, peak 2 years, and definitely then it starts prolonging PR interval, decreased amplitude of the P wave, and widening of the QRX complex. When it gets severe hyperkalemia, definitely the P wave almost diminishes. Then you get different type of blocks, fascicular block, bundle branch block. QRS becomes like bizarre looking, progressive widening, and ultimately you see the sinusoidal wave, and definitely the patient can die with ventricular fibrillation and asystole unless you are really very prompt in treatment of these patients. So few things I'd like to talk about in what type of electrical abnormality, what you expect normally. As you know, that hyperkalemia, we have peaked and tented T waves, and we see different type of widening, as I discussed just earlier, depending on the level of the potassium. It can go to a different kind of blocks, then ventricular fibrillation, asystole, and all these things. In hypokalemia, they're more like the T wave other way. It's not peaked, it's kind of decreased amplitude, the opposite way. Sometimes we can see T wave inversion. Sometimes we can see prominent U wave immediately after the T wave. And that actually, that U wave prolongs the QT interval. And definitely, if severe hypokalemia, patient can have ventricular tachycardia, torsade. When the patient is hypercalcemia, we see shortening of the QT interval, and definitely can have some bradycardic episodes. But hypocalcemia, the opposite. Hypercalcemia, shortening of the QT, hyper, okay? And hypocalcemia, the other way around, prolongation of the QT interval. And both, and they can have also ventricular arrhythmias, torsade. And magnesium problem, there are no unique, electrocardiographic abnormality, though normally they are associated with some calcium abnormality or potassium abnormality. They can have combined effect of those things, but they don't have any unique features on the ECG that you can determine or is specific to that. Let's look at another case, a 63-year-old female with past medical history of liver cirrhosis, type 2 diabetes, heart failure with preserved ejection fraction, sleep apnea, and paroxysmal atrial fibrillation, presented to the emergency department with mainly fatigue and weakness. So that's the ECG. Let's look at few moments. definitely we see something. We see some sinus wave, sinus wave, sinus wave, but we don't see anything here. We don't see anything here. We don't see anything here. Let's look at that and we'll have a poll. All right. Is it atrial fibrillation? Because we see definitely it's irregular rhythm. Is it sinus bradycardia with atrial bigeminy? Is it sinus bradycardia with second degree AV block type 2? Or is it sinus bradycardia with junctional scape beats? Look at the answers and I'll go to the EKG again. All right, let's answer those. So we're getting most of them C, sinus bradycardia with second degree AV block type 2, okay? All right, let's discuss that ECG. Anybody from the trainees would like to discuss the ECG? I'm going to put the ECG again. Tushar, can you ask somebody who are interested doing it? Otherwise, we'll discuss that.
Dhriti can answer, Dhriti.
Somebody answered,
Sir,
but
I don't know, sir. আমার এটা একেবারে পারতেছি না, এটা এসকেপ, মানে এটা তো গ্রুপ বিটিং এর মতো মনে হচ্ছে স্যার, মনে হচ্ছে জাংশনাল রিদম আর গ্রুপ বিটিং, কিন্তু আমি অ্যানসারও ভুল দিছি, আমি মুভিস টাইপ 2 দিছি।
Okay.
তার সমস্যা নাই, তুমি এখন বলো, এখন তুমি কোনটা চাও?
Yeah, you can discuss that. Let me give you some clue here. So look at that and tell me what you think.
স্যার এখানে তো ছোট ছোট আমি জানি না স্যার, আপনি বলুন একটু।
So let's help you. Okay, here's the PR, right? Little bit prolonged PR. So there's a first degree block here, and then we do not see anything, right? No P wave prior to that. So likely junctional scape going on. Okay, PR interval, again sinus, PR interval. And then again, next one, we do not see anything. Okay, junctional beat. And then PR interval, junctional beat. So the correct answer was definitely sinus bradycardia junctional scape beat. Okay, but look at that, few things that we should not miss in this patient. Because first of all, is there any other clue here in the ECG that can help us to understand? Look at that. There's some T wave here, slightly peaked. Okay. And actually this patient had hyperkalemia with potassium of 7.5. Okay. And that caused this conduction abnormality in this patient. All right. So definitely the patient had sinus bradycardia, and on top of that first degree block. They are almost close to 300, definitely first degree block going on, but junctional beat. So it's not like Movis type 2, okay? So sinus bradycardia with junctional scape beats. On top of that, slightly peaked T waves. And that caused this problem. So there's a connection to that. So we don't want to miss, looking at other part of that, not only this arrhythmia problem, if there's anything subtle going on. And definitely as mentioned about, you do the blood work and you see the potassium is elevated, so you know that's probably causing it. All right. And we corrected that. The same patient's ECG is normalized, everything. So we know that is like hyperkalemia caused that. So you shouldn't miss those things. So definitely ECG alone will not tell you what's the real diagnosis on these patients. So as I mentioned, look at the blood work, complete exam, and you see hyperkalemia is the cause, you corrected that, you normalize the patient, patient doesn't need anything else, right? Let's look at interesting case here. 20 years old, presented with altered mental status, young guy, hypotension, basically is in shock almost, and elevated high sensitivity troponin, okay? And this is the ECG on this patient. I'm just giving some clue. There's some ST elevation going on, lead bundle branch morphology, ST elevation going on, and anteroseptal anterior leads and also lateral leads, okay? And we see some accelerated junctional rhythm, probably junctional rhythm. Yeah, I don't see P wave here. So this is the presenting symptoms on this patient, okay? And troponin is elevated. We do not know what's the other situation because patient actually presented with altered mental status, okay? But patient has been in shock situation, hypotensive, and troponin is elevated, okay? Question right now with the patient, you need to take him to the cath lab, give thrombolytic therapy or what else. But look at that initial echocardiogram was done, and let's present that. And it's very poor EF on this patient, it's globally down, okay? And you see the smoke sign on this patient. It's way down. And very, looks like some high echo intensity is high in the and thickened muscles, and also as we see, maybe sometimes myocardial edema could present that way, but definitely way down. Interesting enough, the patient was taken to the cath lab, with this scenario because patient is in shock. He was on pressure support in the ICU and decided to take him to the cath lab, and definitely he had normal coronaries. And patient was in very unstable situation, and finally they did biopsy. They decided to do myocardial biopsy on this patient, and also patient later on. I'm just doing a case here, interesting, that few learning points on this patient. Patient underwent an MRI, and as you see in the MRI, with late gadolinium enhancement, system epicardial, late gadolinium enhancement, and also mid myocardial enhancement. So, and also some pericardial effusion there, okay? And this patient actually had myocarditis, okay? And and the biopsy also, they did right heart catheterization in the same patient because of very, unstable situation on this patient, and was making sure what to do with this patient. And definitely is more, we see the lymphocytic predominance on this patient. So the patient, this type of patient you need to think about in a young patient coming with severe myocardial depression going on. So some sort of either could be viral cardiomyopathy or autoimmune cardiomyopathy, myocarditis. And this type of patients also, and he underwent some good workup, including rheumatologic workup, and his ANA was significantly elevated. It was, and also the double-stranded DNA titer was 1:160. Normal is less than 1:10. Cardiolipin antibodies were elevated, and also he was positive for SSA antibody, and that is normally we see in Sjogren's syndrome, and he met the criteria for lupus, systemic lupus sclerosis. And this patient then was treated with a high dose steroid, 1 gram of solumedrol, like 3 days. And also patient, since his lupus was confirmed, he was treated with also IVIG treatment. And his EF was really low when you saw that, and definitely the patient was treated with guideline-directed medical therapy like Entresto, spironolactone, MRA that we talked about, empagliflozin, the SGLT inhibitors, and spironolactone. And the patient followed up in 6 months in the office, and his ECG was normal, and actually LV function improved up to 55%. Okay, so this case, I'd like to just make sure that you don't miss that, because any young guy, several things can happen with myocarditis. Because I had recently a patient, 22 years old, with viral myocarditis with Coxsackie virus. And we did an MRI. We saw epicardial late gadolinium enhancement. And basically, we treated empirically and guideline-directed medical therapy. And patient had troponin elevation, LV dysfunction. And patient is doing better within 3 months. That patient had another echo, EF improved. You don't want to miss those patients, because particularly giant cell myocarditis, this patient could be terminal if you don't treat aggressively. They do very well, and if you really diagnosed early and good suspicion and treatment with the steroids, another heart failure regimen, the patient might improve. Otherwise, there's a good chance of losing the patient, because I remember one patient I lost. I was working in a secondary other hospital, and I had to fly this patient, a so young guy, and he did not make it in with the helicopter flight. He went to our main Emory hospital, and ultimately he didn't make it. Just on the flight, he died. And it just degraded in front of my eyes. When I saw the patient, within 20 minutes, we called the ambulance, air ambulance. The patient went to a main campus, but by the time he arrived, he coded, and we had to do CPR, but he could not be survived. But post-mortem, he was found to have viral myocarditis, actually giant cell myocarditis. So this type of patients we should not miss. So you have to be very aggressive in the management and treatment plan. Let's do another case. He is a 76-year-old gentleman with past medical history of coronary artery disease, diabetes, paroxysmal atrial fibrillation, hypertension, and he has management for chest pain. He was admitted to the hospital. And this is his ECG. You can look at it carefully. Not very difficult, but look at it and just let us know what do you think. I'll be asking our trainee physicians to comment on that. So what do you think? Is it Morbus type 1, Morbus type 2, sinus rhythm with premature atrial contraction, or it is just AFib? And let's have a poll. Once again, A is Morbus type 1, B is Morbus type 2, C is sinus rhythm with premature atrial contraction, D is atrial fibrillation. You can answer? Right, pretty widespread, okay. Anybody from the trainees would like to discuss that? It's not very difficult, but you try that. Anybody from the trainees? You answered, so you just do your own thinking. Will help you. All right, so let's discuss this case. Here, look at that. Here we see that there's a first degree AV block going on, okay? Peer interval, and then something is there, but there's long pause. And again, few things, the point I like to make, that here the PR interval, initial thought is that PR interval here and PR interval here, there's a difference there, initial thought, okay? So the question right now, there's a true movist type 1 Venkeva going on because this PR interval is shorter than that one. Normally our general idea that within this 3 complex, after the blocked beat, if the PR interval next to it is shorter than the previous one, we normally think it's Venkeva. But is it true Venkeva? That's the question on that ECG and main point I'd like to discuss. Look at that here, the PR interval, the timing, P, and this distance from here to here, and this distance from here to here, this distance is shorter. This distance is shorter, okay? This distance is same, this distance same, this distance same, this distance same, but from here to here, the distance is shorter than the previous one. So it is not true Venkeva. It is a PAC. It is PAC coming earlier, it falling in the AV conduction refractory time, it's not conducting. So it's just PAC, okay? So though it sounds like that, the PR interval is shorter here than here, but the reason is the shorter because immediately after that blocked PAC, you get a compensatory pause. And sometimes we see the decremental conduction in the AV node on the first, normally conducted beat. But then the PR interval normalizes, that patient had baseline. This is not progressive PR interval increasing. Not progressive, this PR interval, and this PR interval is the same. So only PR interval we see slightly slower, slightly, shorter than the next ones because of the decremental conduction immediately after the first, the PAC that was not conducted and compensatory pause. Still, I'm not, it happens sometimes, you shouldn't miss it. And the reason it's not, type 1 Venkeva because this distance of P, this distance of P, and this distance P and P, this coming early when it's coming out, because in Venkeva, this P, and next P will be here, somewhere here. Next P will be somewhere here, but it's coming earlier, a little bit earlier. So that's a PAC. It's not Venkeva. I'm not sure any comment from our EP people on that.
Sir, you are absolutely right that it's a PSC, but strangely it's happening almost in a regular fashion. So it is appearing that Wenkebeki.
That's the important point I like to make, because sometimes we can do mistake, because basically we don't need to do anything, and we need to look at if any other causes of having some too many PSs, electrolyte abnormality or anything going on this patient, okay?
So thank you very much.
Okay, I think we can stop here, right? Yeah.
It is almost 10:43 p.m. at Dhaka, and it's quite excellent presentation regarding the content. So I'd like to request Professor Atahar Ali sir to have his comment on the presentation and the discussion.
Before that, there are some our new faculties. Sharodindu, can you hear us?
Yes, sir. Yes, sir. I can hear, sir.
Nice to see you, Sharodindu. This is a very, this is a man who likes ECG very much. Sharodindu.
I am grateful, sir. Thank you. Thank you very much. And I enjoyed a lot in today's presentation, particularly. And the cases were very nice, and I enjoyed a lot, sir. Thank you. Thank you very much, sir.
Thank you, Sharodindu, for being with us. Asadul Zaman.
Asad bhai is very busy now. I don't think.
Thank you, sir.
ও যাক, আমি তো ভাবছি আপনি এখনো বেরোতে পারেন নাই।
So nice to see you, Zaman, please.
Thank you, sir. Actually, it's a truly an honor to be here today as a part of this distinguished panel for this ECG session. I'd like to express my gratitude to the organizer for arranging an important session and insightful scientific program. Basically, in today's session, I look forward to learning from my esteemed colleagues and exchanging the thoughts and discussion challenging ECG cases that will enrich our collective knowledge. Thank you, sir, for inviting me to say a few words. Thank you again.
Thank you, Zaman. Is there anybody to comment among the participants and faculties? So Azizul, thank you very much for your excellent presentation. This is the real world cases. That is the real life practical cases today we have discussed. Really, I thought that these are my cases. These are the cases are selected in such a way that every case seems to be that this is my case. So nice discussion. I learned a lot from this today's presentation. Excellent case selection and nice presentation. And I request Aziz Bhai to present similar and such cases in future again and again. Thank you very much.
Thank you. Actually, ECG is certain things that you need to repeat again and again. And a lot of things, I need to make sure our trainee physicians, they don't miss the common things. We don't want them to, look into very difficult cases. That's why EP are there. But normal things, normal MD trainees should not miss common things. So we need to really discuss thoroughly, make sure they understand it. And not only that, then they should be able to explain why it's happening. Otherwise, just memorizing or looking into that, it doesn't really help us. So my goal is to make sure they understand thoroughly exactly why it's happening and why it's not the case, the other answers. So if you can analyze that way, probably you'll understand it better and definitely you'll come to the better diagnosis. Thank you very much.
Thank you very much.
Thank you, sir.
So inviting everybody for our next session after 14 days. And today we can conclude the session. Tushar?
Yes, sir. Thank you, sir. We will let the topic and the presentation date in the November by on the WhatsApp and Facebook page. Thank you to every participants, physicians, and also our scientific partner, Beximco Pharmaceuticals, for being with us. Thank you, everyone, and good night.
Thank you.
Thank you. Thank you, everybody.